Hello and welcome back. So today I'll be discussing the imaging of chronic focal and multifocal consolidation. This will be a fourth video in the general heading on an approach to chronic shortness of breath resulting from focal or multifocal consolidation. So as we've discussed previously in our general approach to pulmonary opacities, consolidation may be acute, it may be chronic, and when it is chronic, it may be focal or multifocal. Okay. Diffuse is not really an option in cases of chronic consolidations, and chronic consolidation definitionally are ones that have lasted for more than 4 weeks. And when you don't have an old scan or a documented radiology report showing that there was a consolidation for more than 4 weeks, that would be with features of chronicity, so such as fibrosis usually. Okay, so that's where we were. Now let's get to how we are going to build up to the logical evaluation of pulmonary consolidation and how it can help us clinically. So this will be an approach. So basically I take a 4-step approach. The first step is to determine all possible clinically feasible differential diagnosis. This is based on an approach to chronic focal and multifocal consolidation. This is what I've discussed in the previous 3 talks. So that is particularly part A, that was an approach to chronic dyspnea secondary to chronic multifocal or focal consolidation. The second step is to see if there are any imaging features suggestive of atelectasis that might be the actual pathology, and it's not really a consolidation. So in the next talk, which will be our final one on approach to chronic focal or multifocal consolidation, I'll be going into the details of what the imaging findings of an atelectatic consolidation are. So if that is the case, we go in for accordingly we manage, and if we're suspecting a malignancy, we go ahead and do a dedicated workup for infection and or malignancy. Okay. Now on the other hand, you may have no features of atelectasis. In that situation, we screen for imaging findings suggestive of infection and or malignancy. This was discussed in our approach to chronic dyspnea part 12, that is the general approach to pulmonary parenchymal opacities. Those general principles will apply here, and if there is anything suggestive of an infection or a malignancy, we would do a dedicated infection or malignancy workup. Now just to jog your understanding, what would be features that are suggestive of infection? That would be a tree in bud pattern of nodular interstitial opacities. So if it is tree in bud is just a derived variation of our central lobular pattern. Okay, so that's a central lobular pattern, and we discussed that infections, particularly bacterial infections, pass through 4 stages. This could also be the case with DNA viral infections, but yeah, bacterial infections, they pass through 4 stages. That is, first there's a central lobular opacity, which progresses to tree in bud, which then becomes multifocal or multi-assigner opacities, which then become consolidation. So if you find a constellation of these findings, you're already suspecting a infective process. On the other hand, malignancy, 14 different parameters that we have to look for, and I had gone into this in some considerable detail there, that would increase or decrease the probability of a malignancy. So if you are suspecting an infection or a malignancy, the only way to diagnose an infection is to demonstrate the presence of the organism. Okay, and the only way to diagnose a malignancy is to show histopathologically that it is a malignancy. Okay, so that is the only way we will be able to move forward. So that would indicate requirement of a biopsy or a histopathological sample. Okay, in case of infection, a bowel or bronchoalveolar lavage might suffice. Again, if there are no features suggestive of atelectasis, and you don't primarily think that this imaging, this clinical picture, as well as the imaging, is compatible with a diagnosis of an infection or a malignancy, Alternatively, you have considered an infection and you have treated the patient empirically with antibiotics, and still there are findings that are apparently not resolving. You would then consider the next step. So the next step is you screen for associated imaging findings, and in some specific imaging findings, you can consider the possibility of a specific underlying etiology for a consolidation, and that is what we'll be going to in detail in this particular talk. So if that is not the case, again, workup as based on the clinical pretest probability, that is obviously based on our understanding of what may be the causes of focal or multifocal consolidation in general, which we discussed in our first talk in this series. And if again you are suspecting infection or malignancy, be very, very careful to rule out infection and malignancy. Now, provided that all of this has happened, so this is a pretty big if clinically, you can move ahead and you can look for other findings in imaging. In this situation, we do a highly targeted workup as per clinical and radiological pretest probability. So I have discussed how to assess the clinical pretest probability in this particular situation. Now today I'll discuss how to assess the radiological pretest probability. Okay, so just as a shortcut, when you're looking at a consolidation, it takes a little bit of time to come up with the entire diagnostic framework. So as a shortcut, you can remember that once you see a consolidation, all causes of a chronic focal or multifocal consolidation are mean. Okay, all would stand for amyloid, L for lymphoma or malignancy. L would also stand for alveolar space, which is diffuse alveolar hemorrhage. Then mean is, as we've discussed previously, mycobacterial infection, endemic mycosis. E stands for endemic mycosis, A stands for actinomycosis, and N stands for nocardiosis. Okay, now I presume many of you would have already seen this axial section multiple times in my videos. This is a multifocal consolidation with a peribronchial distribution associated with some surrounding GGOs. Okay, so now, as I have discussed already, a lot of pathologies could technically explain this type of imaging pattern. So it could be organizing pneumonia. Okay, that shows a peribronchiovascular pattern. Chronic eosinophilic pneumonia, again, both are not radiologically different. You cannot differentiate between them radiologically. Or it could even be granulomatosis with polyangiitis. So how do I proceed? It could even be a viral pneumonia, because I told you in viral pneumonias, particularly your RNA viral pneumonias, you often have a GGO which is then progressing into a consolidation. So you get a combination of these two. Okay, so the clinical context makes a very big difference in these cases. Obviously, a chronic multifocal consolidation would not be due to a viral infection. That is something that would be odd. But yeah, in an acute dyspnea case, that could easily be COVID pneumonia. So how do we proceed? So what we do is we first look at one thing, that is, we must understand that infections and malignancies don't usually show a peripheral or peribronchiovascular distribution. Okay, that is something that must apprise us to the likelihood of a alternative explanation for this particular pathology. That is something that is something that should immediately make you wary of alternative diagnosis. Okay, so amyloidosis related consolidations have a very variable distribution, and right now I'm not going to go into details of this. At the end, as we go through the talk, you'll see how that is relevant. Findings other than consolidation, if present, allow differentiation. Like as I said, a lymphoma or an adenocarcinoma may have a corresponding interstitial distribution. So that would be a nodular interstitial opacity, specifically a perilymphatic, as we've discussed previously. Or it might have a carcinoma in situ may have a pure GGO like presentation. Now, similarly, a chronic infection would, as I've just discussed, might have features of other stages of the infection. So you may have a centrilobular nodular interstitial opacity, you may have trine, but you may have multi-acinar opacities, and you may just have a full-fledged consolidation. And endemic mycosis, owing to their relatively slow growth rate of the fungi, may actually have mass-like lesions. Okay. On the other hand, we could also have decreased pulmonary attenuation. So that would be technically a cavity. And we'll discuss how to differentiate between a malignant cavity and a non-malignant cavity just subsequently. Now, both organizing pneumonia and chronic eosinophilic pneumonia have GGOs, often around the consolidation or sometimes surrounded by the consolidation. GPA would have some very interesting findings that we'll get into just now. So that includes a centrilobular nodular interstitial opacity, but this would not be well defined. Not well defined. These would be ill-defined centrilobular opacities. There may be features of alveolar hemorrhage, and there may be ground glass opacities. So what this is a carcinoma or lymphoma presenting primarily as a non-consolidative process. So as you can see here, this is a ground glass opacity. As you can see the vasculature within. This is a interstitial nodular opacity, and what you see is that the interstitial nodular opacity seems to have nodules that tend to have some cliquey clustering, or they tend to have social clustering. They tend to like to talk to each other. See, look at these nodules here. Similarly, they are not showing any sparing of the fissures, the interlobar fissures, and they are also not showing any sparing of the parietal pleura. Now, as I've discussed in our previous discussion, one characteristic finding is studding of the pulmonary artery, and you can see this is the pulmonary artery, and around it there is studding. So this is definitely a perilymphatic nodular interstitial pattern. Okay. On the other hand, chronic infections would have a tree in bud nodular interstitial pattern. So why am I calling this a tree in bud pattern? Again, it is sparing the pleura. It is sparing the interlobar fissures. There is no pulmonary artery studding, and the nodules seem to be joining into each other. So they produce a tree in bud pattern. Miliary or random pattern implies hematological spread, and therefore it is not specific for even an infection. It could be specific for, and it just means hematogenous, as we've discussed previously. Now, lung cavities may be malignant, may be infective. Wall thickness is an important factor other than for associated findings that helps you differentiate. So wall thickness of less than 7 millimeters strongly indicates in a benign or infective cause of the cavity, and a wall thickness in excess of 24 millimeters strongly indicates that it is a malignant cavity. Now, the presence of other features of infection, again, centrilobular opacity, nodular or interstitial opacity, tree in bud nodular interstitial pattern, multi-acinar consolidation, and perilesional consolidation all indicate that the opacity is likely infective, whereas the absence of these findings indicates that it is a malignant. A lower cutoff of 15 millimeters can also be used, but using a cutoff of 23 millimeters or more of wall thickness provides a sensitivity of around 45% and a specificity of 97% with an LR positivity of almost 15 times. Peribronchial consolidation with surrounding GGO could either be organizing pneumonia or chronic eosinophilic pneumonia, and as I've discussed multiple times before, these entities are essentially radiologically identical. Now, coming to the centerpiece of this talk, so that is focal and multifocal consolidations, where the findings strongly suggest an underlying etiology. Okay, so this would be, I use the mnemonic cigar here because again this is essentially disorders that are infiltrating into a tissue and therefore are causing tissue enlargement. So S stands for sarcoidosis, I stands for IgG4 related disease, G stands for granulomatosis polyangiitis, A stands for amyloidosis, and R stands for raised IL-6 levels as in Carcellman's disease. Okay, so in sarcoidosis, the most important and prevalent imaging finding is actually symmetric hilar mediastinal lymphadenopathy. Usually lymph nodes are quite large. That is also something that you need to understand. Now, when you do a contrast enhanced imaging on axial sections, you may see multiple small 1 to 2 millimeter nodules distributed uniformly within the node, and this is called a cluster of black pearl sign because the nodules actually are granulomata which don't take up contrast, whereas the rest of the lymph node enhances. Now, another very important thing is that the lymph nodes are usually larger than 2 centimeters in the shortest axial diameter. Now, other parenchymal lung findings that might be there in sarcoidosis include nodulosis, which we've discussed, is perilymphatic micronodular patterns. You could have a consolidation with surrounding, multiple nodules in a perilymphatic pattern, which has been given the moniker of the sarcoid galaxy sign. Then you could just have a GGO, you could have mosaic attenuation, and you could have a miliary pattern. Now, fibrosis occurs in around 20 to 25% of sarcoidosis cases, and less common findings that you might get is actually a consolidation. So when you see a consolidation, sarcoidosis is much lower down in the list, both clinically and radiologically, just because it is unusual for sarcoidosis to cause consolidation. When it does, it is called alveolar sarcoidosis. Now, pleural effusions are actually very uncommon in patients with sarcoidosis, and if you have a pleural effusion, strongly suspect tuberculosis and go out of your way to rule out tuberculosis. And when present, they are almost always small to moderate in size and resolve within 2 to 3 months. Now, coming to the second entity, that is IgG4 related disease. So again, this usually doesn't have consolidations. Okay, so one is it produces, just like sarcoidosis, multiple hilar and mediastinal lymph nodes, and this is the reason why when I discuss immunology, I'll be comparing the clinical features of these two entities. The second pattern could be an NSIP ILD with diffuse granulous opacities and interstitial septal thickening. So again, note the distribution of the nodules, it is perilymphatic. Again, why is it perilymphatic? Because they're showing clicky or social clustering. They show pulmonary artery studding, although there would be an argument here that this is a peribronchovascular pattern rather than a definite perilymphatic pattern. But yeah, you can see both sides having some merit to them. There may be multiple parenchymal nodules which then show secondary cavitation. So again, this would prompt you to think infection, think malignancy, but also in the specific clinical scenario, IgG4 related disease. Now, this kind of diffuse GGO with interstitial, septal thickening is something that you also get with sarcoidosis and Castleman's disease, other two entities that are there in this list. Now, the next entity we are going to talk about, and we're going to discuss this in detail because I want to highlight a few of the imaging findings and what might they represent. So that is GPA. Epidemiologically speaking, the most common imaging findings in GPA are in 40 to 70% of patients are pulmonary nodules and masses. Now they are a bummer. So what is bummer? They are bilateral, they are multiple, and they show random distribution. Okay, they are randomly distributed. So having gone through that, usually the nodules are round to oval in shape. They range in diameter. They could be very small, of a few millimeters, and up to 10 centimeters in size. And when these lesions are larger than 2 centimeters, they're more likely to undergo necrosis, central necrosis and cavitation. So around 1/4 of all nodules that are larger than 2 centimeters tend to cavitate, again increasing the possibility of malignancy. So in this situation, you're again thinking, okay, infection, maybe a malignancy. Then when do you suspect GGOs? One thing is that there are often in GPA other imaging findings that suggest the angiocentric nature of the lesion. So this is naturally a vasculitis. So the inflammation is centered around and predominates around the blood vessels. So what findings could that produce? So that produces one, bilateral patchy consolidations, okay, and granular opacities. So now because the lungs get their blood supply centrally from the hyla, often these lesions tend to accumulate around the hyla region of the involved lung. Okay, the second finding that you might get is you might have a area of consolidation with a central area of GGO. So GGO in the center and consolidation in the periphery. So this is actually called a atoll sign, as an homage island archipelagos that are formed by coral reefs. So this would be the reef, and this would be the shallow water within the enclosed by the reef. So that is called the atoll sign. So atoll sign obviously also occurs with your organizing pneumonia and chronic eosinophilic pneumonia. Now, however, see, organizing pneumonia and chronic eosinophilic pneumonia are not due to inhaled antigens. So they are not an infective process. So they are unlikely to produce a central lobular pattern, or they won't produce a central lobular pattern. Now, on the other hand, as I've discussed previously, even though the centrilobular pattern is almost always can be due to inhaled antigen, it could also be due to vasculitis. And in GPA particularly, because of actually inflammation of the vasa vasorum of the vessels that are that are supplying the bronchopulmonary lobule, you may get inflammation of the entire vessel, and you can actually then develop a tree in bud pattern, although a tree in bud pattern still strongly indicates that it is an infection rather than a vasculitic process. These are the two things that you might get. Okay, so you might get a halo sign or a reverse halo sign. You might get tree in bud nodular interstitial opacities, and there is another finding, that is feeding vessel sign, where, as you can see in this particular case, there is a consolidation here, and near that consolidation there is a little bit of a GGO, and there appears to be a vessel that is going directly into the consolidation. So this is called the feeding vessel sign, indicates that the lesion is angiocentric, surrounding a blood vessel. Okay. Now coming to amyloidosis. Amyloidosis has varied presentations. It could be, one of 4 patterns of pulmonary amyloidosis have been described. Pulmonary amyloidosis is almost always associated with AL amyloidosis. The 4 patterns are diffuse alveolar septal involvement, which is a combination of GGOs or consolidation and septal thickening, nodular parenchymal type, and we'll see as we go ahead other patterns. So the alveolar septal opacities are, as you can see in this particular case, interstitial septal thickening, okay, along with surrounding GGO. In this area of the lung, there is consolidation, again with septal thickening. The second thing, as we've discussed, is a diffuse tracheobronchial involvement. So tracheobronchial involvement results in tracheobronchial thickening. And how do we define that? We define that by comparing the wall of the respiratory tract with the fissures. So usually in a normal lung, the wall of the tracheobronchial tree should be as thick as the fissure. It should not be thicker. Okay, so if it is thicker, you're thinking of a tracheobronchial thickening, which could be due to explained by amyloidosis. Finally, you could have a nodular parenchymal nodular amyloidosis, and you could have hilar lymphadenopathy. So this is a nodular parenchymal amyloidosis with secondary calcification, and here you can see that there is a hilar lymphadenopathy, and on CT you can see that it is actually been calcified. So another finding that you might get is cysts with amyloidosis are associated with, it's a pattern of cystic lung disease associated with nodules. So what is the differential diagnosis? The differential diagnosis may be cystic metastasis and pulmonary Langerhans cell histiocytosis. So amyloidosis, being a process that is centered around the airways, shows a diffuse or lower lobe predominance. Cystic metastasis obviously come via the bloodstream. So since they come via the bloodstream, they are likely to be more prominent in the lower lobes. Pulmonary Langerhans cell histiocytosis is actually a type of smoking associated lung disease, and smoke is literally the reason why it is happening. So it predominates in those parts of the lung where the ventilation of the lung per respiratory cycle is lower. So that is the upper lobe, where the smoke, once it enters, stays for a longer period of time, as we've discussed in our discussions on the pulmonary symptomatology. Now, the shape of amyloid nodules is usually round to lobulated. Cystic beds can vary in shape, maybe round in particularly renal cell carcinoma and those arising from the genitourinary tract, but they may be variable in shape. Pulmonary Langerhans histiocytosis, initially the nodules are round centrilobular nodules. Later on they become bizarre shaped and stellate, and they can then secondarily form cysts, which again have a bizarre shape. So the main thing that helps you differentiate these causes of cysts with nodular opacities is actually the presence of the other findings, that is the ground glassing, the interstitial septal thickening, and the mediastinal lymphadenopathy, which would occur with amyloidosis rather than the other 2 entities. Now finally, respiratory involvement in Castleman's disease can be very characteristic. So in Castleman's disease, you could again get these multiple nodules. These multiple pulmonary nodules can also be associated with a paravertebral mass, a pleural paravertebral mass. So now the thing is that some of you, who are aware of the imaging findings of IgG4 related disease would understand or would recall that paravertebral VAS is one of the imaging findings that actually occurs with IgG4, and I have not really discussed it under that heading. That is because there is a lot of impetus put on paravertebral involvement in IgG4 related disease, and although Castleman's can closely mimic that, it is not given enough credit for presenting like this. So I wanted to counter that. That is why I put it here. But yeah, it does occur with IgG4 related disease, but it occurs with both IgG4 and Castleman's disease. There are subtle imaging findings that help you differentiate it, that we'll be getting into when we discuss these two, the differentiation of Castleman's from IgG4 in the illness script of IgG4 related disease. There are three other patterns that you might get with Castleman's. You might get airway opacification, usually a ground glass opacity more than a consolidation. You might get bronchiectasis, and you might get central lobe knowledge. So in these five entities that I've discussed, it is the constellation of findings or the combination of findings that indicates that the diagnosis, specific diagnosis other than infection or malignancy. And obviously, I wouldn't suggest that unless a malignant process or an infection has been ruled out, you start trying to diagnose these disorders. Okay, so only if you go through step 2 and step 3 can you come to differentiation of these five disorders on imaging. So that brings us to the end of our discussion on an imaging approach to chronic focal and multifocal consolidation, and I hope it is clear that you need to go step by step and you shouldn't skip steps, because then you'll end up over diagnosing entities like GP and sarcoidosis. But when used appropriately, it helps you diagnose cases with a high degree of accuracy. So thank you, and in the next talk we'll finish off our approach to chronic dyspnea secondary to chronic focal and multifocal consolidation by delving into atelectasis as a cause of this kind of a consolidative image. So thank you, and I'll see you next time.